Hello, this is Lindsay Luther. This is part 3 of your Women's Health series called Gynecologic Dysfunction. There are a lot of ways in which the gynecologic system can malfunction, and this lecture is not going to teach you every way that the gynecologic system can fail, but instead I want to give you an approach to encountering women's health pathology, some information about how to perform an adequate workup, and some characteristics that will distinguish one problem from another. So I would suggest that you listen to my commentary, read over any sections which you feel like you need some more study on, and then ask yourself what elements of the history and physical might point towards each diagnosis as you're going through. That's going to be the most effective way to study these different types of dysfunction. You'll continue to see them pop up throughout your clinicals. Each time you come across a type of pathology that you're just not that familiar with, or when your preceptor is prescribing a medication and you're not sure why is that the medication that you use as opposed to something else, first of all, ask your preceptor to talk you through their reasoning for choosing what they choose. The next thing is always go back and read a little bit more about the diagnosis. If you have a chief complaint, you might start there and read in your 5-minute clinical consult or in your differential diagnosis book what are the things that can cause this, and then just keep an open mind until you have enough information to point you towards one specific diagnosis or another. Okay, so the first section of this is going to be about breast symptoms and breast disorders. I've posted a podcast for you to listen to all about breast disorders, and so I'm not going to go through this section in much detail. I do want to just give you a couple of quick tips or pearls as far as how to approach breast complaints. So whenever a woman comes to your office and is complaining about a breast disorder, you're always going to get a very complete history, and you want to further characterize symptoms and determine how likely it is that this problem could represent a breast cancer. Your history will include old carts, medication use, physical activity, breast stimulation, any history in the family or in the personal self of breast or malignant disorders, the woman's reproductive history, and then you want to do a thorough review of systems to see if there's anything else that could be causing the problem. You want to keep in mind that the breast complaints can come from many types of etiologies. So it could be a problem with the endocrine, the dermatologic, the musculoskeletal, or the neurologic systems, or it could come from medication use. The next part is the clinical breast exam. The goal of the breast exam is to figure out whether or not the breast symptom is coming from the breast or if it's coming from one of those other systems. If the patient has bilateral findings, this is more likely to be a systemic disorder or to be a variation of normal, so something that's physiologic rather than pathologic. Okay, so I'm going to give you just a couple pearls from each of these slides. When you're talking about breast pain, you want to know that it's very common. The key distinguishing feature in breast pain is going to be cyclical versus non-cyclical. Cyclical breast pain is almost always physiologic as opposed to pathologic, and it has to do with hormone production. If it's not occurring in relation to the woman's menstrual cycle, that's when you're going to start looking for things that could be problematic. So that's when you need to really dig into that history as far as what else could be going on that could be causing problems. Whenever the patient has a non-cyclical breast pain, you want to figure out if there's any associated symptoms, especially those that could also indicate a breast cancer, so things like the nipple retraction, dimpling, peau d'orange, or the skin changes, etc. So these are your history and physical questions that you're going to pay attention to. In terms of the workup for breast pain, if there is a potential for breast cancer based on your history and physical, you are going to do imaging. If there's no suspicious findings, you're probably going to just make sure that their cancer screening is up to date. You can still do imaging if you think it's going to provide reassurance for the woman, and we choose our breast imaging based on age. However, if there's a normal physical exam, the imaging is unlikely to provide further information because the risk of cancer is so low. There is treatment for breast pain. Primarily, you're going to use over-the-counter medications and supportive measures, so things like hot and cold and bras. You can also alter the estrogen dosage if the patient's using contraceptives or hormone replacement therapy. And then there are some second-line medications such as danazol or tamoxifen that reduce estrogen-related side effects. Okay, nipple discharge. We're not going to go too deeply into this because it is well covered within that podcast. Keep in mind that it is normal and common for a very small amount of clear discharge to come from the breast. We get more concerned if the breast discharge is milky and inappropriate or if it is bloody. Some principles about breast lumps. They can be benign, they can be malignant. They're usually found by a partner or they may be found during a clinical or self-breast exam. They may or may not be associated with other changes to the breast. A clinical breast exam by an expert actually has a very good sensitivity rate. However, typically this is not enough to be reassuring. So although we know that most of the time an expert can pick out a breast cancer up to 93% of the time and rule out a breast cancer up to 87% of the time, that remaining percentage is not enough to make the woman feel super great about that, which is why we rely on imaging. Okay. Oops. Sorry about that. So you've gone through this in your podcast, or you will in a moment, but these are some of the history and physical exam characteristics you want to pay attention to. One pearl for documenting findings. The easiest way to document is by using the clock method. You can see here that the clock method uses the position of the hands on the clock to indicate where the position is on the breast. This is a left breast, and so 1 is towards the axilla. On the right breast, the 1 o'clock would be towards the midline or towards the sternum. You also see that the mass is described by its location from the nipple line or from the areola and also its diameter. You also want to make sure that you document skin texture, whether there's any alterations in the tenderness, discreteness, or consistency of the mass, if there's any other symptoms associated with it. So what I want to point out to you about breast workup is that, like everything else, your history, your physical, your cancer risk assessment are really the key components that will start your workup. From there, you can order imaging on an age-appropriate basis. And then when you get imaging of the breast, you will get a score called a BI-RADS score. The BI-RADS score is a radiology criteria score that's given to you by the radiologist based on how suspicious breast imaging looks. So the higher the number on the BI-RADS score, the more likely that this is something that needs to be dealt with. And so your treatment will depend on not only what type of tissue the lump appears to be, but also by its BI-RADS number. Another note, you just want to be very careful that whenever you send a patient for imaging, that you make sure that the results of that imaging are followed up. This is a rule of thumb with all workup. Anytime you order a test, you better be sure that you see the results of that test and that the results of that test are communicated to your patient. And so that's something that you'll need to work with your practice on to make sure that they're doing this in an efficient way. So selecting appropriate breast imaging, if the patient is under 30, they're probably going to do an ultrasound. If the patient is over the age of 30, they usually start with diagnostic mammography in a woman who has a palpable mass. They usually will do an ultrasound, especially if the woman is between the ages of 30 and sometimes it's 40, sometimes it's 49. And that is because sometimes ultrasound will find lesions that the mammogram does not. The preferred test has to do with the density of the breast, and that is very well correlated with the patient's age. So I do want to point out to you that you should be aware of the characteristics which make a person at higher risk for breast cancer. The population here on the right, the individuals who have had atypical hyperplasia, a history of LCIS, or they have a positive BRCA gene or other familial cancer syndrome. These are the women that we're going to recommend that they consider at least some type of risk reduction therapy. Typically the medications we use are tamoxifen, raloxifene, or aromatase inhibitors. Okay, so now that we've gone really quickly through the breast, we're going to get a little bit into gynecologic and menstrual disorders. The first one that you're probably going to see a little bit of in your practice is pelvic organ prolapse. So in pelvic organ prolapse, either the bladder, the uterus, or part of the rectum or the bowel is um, bulging from its normal space and compressing the vaginal canal. You can see here in A, the bladder is moving forward and compressing the anterior wall of the vagina. And then you can see here in B, this is a rectocele, so part of the rectum has moved forward and is compressing the posterior wall of the vagina. And then in C, it's the upper portion of the bowel is moving down here and again compressing the posterior portion of the vagina. The cervix can also move down sort of into the vagina and shorten the vagina. Sometimes if a woman has a uterine prolapse, they will actually see the cervix protrude from the vagina. The primary feature of the history will be that a woman complains that something is falling out of them or they have a bulge that comes and goes. There are some other associated symptoms, for example, painful intercourse, bladder concerns, low back pain. Women will typically describe this as irritating rather than painful. Treatment is going to depend on the size of the defect or the number of defects, so it's not uncommon for a woman to have a uterine prolapse and a bladder prolapse or a cystocele and a rectocele. And if they have multiple defects, they're more likely to need surgery. If they only have minor defects or do not want to pursue surgery, options include physical therapy or the placement of a pessary, which is basically a firm support agent that sits inside the vagina and helps to maintain the walls of the vagina. Okay. So moving forward, we're going to talk briefly about amenorrhea. Amenorrhea is divided into primary or secondary amenorrhea. I'm sorry, this should say secondary, and I'll fix that when I post the slides. So primary amenorrhea is any time that a girl has not had a period by the age of 14 and is also not developing secondary sex characteristics, or if they do develop secondary sex characteristics but still have no period by the age of 16. Secondary amenorrhea is when there is no period for at least 3 months after the time of menarche or after the establishment of normal cycles. Primary amenorrhea, I just want you to have an understanding of how we go about the diagnosis for this. Treatment is going to depend on the cause. So the very first thing you have to rule out whenever a patient comes to you with a chief complaint of no periods is, are they pregnant? Because ovulation happens 2 weeks before your period starts, it is possible for a woman to get pregnant before she ever has her first period. There are also other causes, including structural abnormalities, which prevent blood from getting to and leaving the vagina. There are issues with the gonads, so the ovaries, the uterus, etc. And then there may also be endocrine abnormalities, such as those found throughout the HP axis. Workup for this is going to start with a history and physical, including to check for structural abnormalities. Next part is that you're going to do some basic endocrine labs, including a pregnancy test, FSH, thyroid stimulating hormone, and prolactin levels. Next, you will do a pelvic ultrasound just to make sure that all those structural elements are present. And then from there, you're going to take this information, and there are a lot of diagnostic and treatment algorithms that you can use to help you determine the next step. I'm not going to go into each of those today because it's way more than what you need for this, but just know that these exist and that you need to be able to access these algorithms so that when you're in practice and you see something, or when you get your results back from your FSH, TSH, prolactin, you know what to do with them. So secondary amenorrhea is basically it's the absence of menses after an established period of normal menses. This can be a functional problem. So basically the estrogen gets low because there's something else in the system that's messing things up. So stress, starvation, exercise. There can also be another issue with the HP axis. So there may be a structural abnormality of the pituitary, such as a tumor or an infarct of the pituitary. Your prolactin levels could be high, or there could be Cushing syndrome. Ovarian dysfunction, such as primary ovarian insufficiency, which is an early onset of menopause, of the ovaries ceasing ovulation too soon in a woman's age, or PCOS can cause this. A syndrome called Asherman syndrome results in the fibrosis of the endometrium. So that's a structural issue. And then there are medications that can cause this. So again, your history, your physical are going to be the most important thing. You're looking for anything that could suggest to you that there is an endocrine issue, a stress issue, there might be problems with the weight or with the patient's behavior. When you get to your physical exam, an eye exam and skin exam can help you to determine if perhaps there's something else going on in terms of elevated androgen levels or elevated prolactin levels or thyroid abnormalities. Okay, abnormal and dysfunctional uterine bleeding. Anytime the period is prolonged, heavy, or there's bleeding between cycles, or you have excessively frequent or infrequent menses, that can be defined as abnormal or dysfunctional uterine bleeding. The most common cause of this is fibroids, but there are many, many causes of this. The first line treatment is either, the first thing most people will do is put a patient on an estrogen pill. You can use birth control pills, but they have to be given at much higher doses and multiple times a day for several days. That can be done to stop acute bleeding. From there, treatment with oral contraceptives can continue if the patient is not seeking pregnancy or the placement of a Mirena or Skyla IUD. NSAIDs can reduce the rate of prostaglandin synthesis in the endometrium, and this causes vasoconstriction. This is one reason why, one of the reasons why NSAIDs are tremendously helpful in this population, and not just for discomfort, but also for heavy bleeding. And these are really cheap, and they can be taken when the patient's bleeding. I will warn you that patients who have an IUD placed for this problem, it is a very effective treatment. It's as effective as an endometrial ablation. However, there's a high risk of expulsion. So if a patient has dysfunctional uterine bleeding, the risk of expulsion is about 10%, compared to normal is about 2 to 3%. And then if they have uterine fibroids, the likelihood of expulsion actually goes up to 25%. All right. Dysmenorrhea. Again, there's primary causes and there's secondary causes. Primary dysmenorrhea is extremely common. Up to 85% of women may have discomfort during their menstrual cycles, usually for the 2 to 3 days immediately before and at the onset of menses. They may have pain that radiates to the low back, thighs, may have nausea, vomiting, bloating, malaise, or other symptoms that we call PMS symptoms. The key to distinguishing primary from secondary dysmenorrhea is the presence of a normal physical exam. If the exam is normal, they have primary. This means there's not really a whole lot you can do about it except symptom management. If the patient has an underlying pathology, there are many things that can cause this. The most common thing is endometriosis. Again, a good physical exam, a good history are going to help you to distinguish when this is pathologic versus physiologic. I did a relatively intensive section in here on endometriosis because this is a problem that doesn't get as much attention as it should. It is a lot more common than we give it credit for, and it's one of the number one reasons why women have infertility. So, and it's one of the primary causes of pelvic pain. We don't really know what causes it. There are many theories, and I've discussed that in the slideshow notes. We don't exactly know why some women experience such severe symptoms. The level of disease does not seem to be directly correlated with the amount of symptoms that the woman has. The key history items here are going to be pelvic pain, which may or may not occur during menstruation, but usually occurs cyclically. They may have ovulatory pain, deep dyspareunia, painful bowel movements, dysuria, which comes and goes in cycles as well, infertility, and a pelvic mass. They may also on their physical exam, they may show signs of adhesions or fibrotic lesions. They may have palpable masses on their ovaries, and they may have these lesions that are black, gray, deep red, purple, yellow, white, or scar-like that kind of engorge and regress over time. So there are a number of things that you have to rule out with endometriosis. Diagnostic criteria, unfortunately, the only way to confirm this is with laparoscopy, so surgical procedure. But most women are pretty eager to have this done if they think that that's what's causing the problem, because not only can it help with the adhesions and the pain associated with it, but getting a diagnosis is really helpful to patients. So treatment, there's two goals. There's two goals and they're kind of debated. One goal is the relief of symptoms and the other is resolution of disease. We do know that because symptoms are not necessarily related to the amount of disease, that the goal is really sort of shifting towards symptom management. There is initial pain management with over-the-counters, and opiates can be prescribed if the pain is severe. Hormonal treatments have a good efficacy, but some of these women will hope to become pregnant, and so that may not be the preferred approach for those women, and this is something that needs to be pursued on an individual basis. Surgery can be performed to remove ectopic lesions as well as adhesions, but a hysterectomy and an oophorectomy do not necessarily eliminate symptoms for all women. You've probably heard a little bit about PCOS in the greater media and in your personal lives. It is another primary cause of infertility. It's also very common, and it is associated with ovulatory dysfunction and high levels of androgen. Because of that, these patients will also have increased risk for metabolic and cardiovascular disorders, as well as endometrial cancer. So when you're doing a differential diagnosis for PCOS, your primary goal is to eliminate other causes of endocrine and gynecologic dysfunction. The fact that the patient has polycystic ovaries actually doesn't have a lot of clinical significance, so that's not really the place that we go looking first. We're really looking on the endocrine side of things. The goals of treatment are going to be to reduce as many of the signs of high androgen levels as possible, so a lot of those bothersome symptoms of hairiness, acne, male pattern baldness. We want to reduce risk factors for endometrial cancer, cardiovascular, and metabolic disease. And then we also, because these patients ovulate in such a random fashion or such, not a cyclical fashion, we need to be careful that we either help the patient prevent a pregnancy if they're not hoping to get pregnant, or we may refer them or assist them in helping them to induce ovulation if they do want to get pregnant. So treatment is going to include weight loss especially. Oral contraceptives or progestin-only contraceptives can be helpful if the patient does not want to have a pregnancy. If those are not effective alone at getting rid of those androgenic symptoms, you can also add spironolactone. Metabolic treatments might include things like bariatric surgery, weight loss medication. Metformin is used a lot for insulin resistance. And then the thiazolidinediones, I cannot say that word, I apologize, and statins are also used to treat both the metabolic syndrome and hyperlipidemia, diabetes that often go alongside PCOS. Postmenopausal bleeding, if there's one thing that you need to remember, it's that it's very rarely is postmenopausal bleeding caused by cancer. Less than 10% of the time is it due to endometrial cancer. However, you absolutely have to assume that it's endometrial cancer until proven otherwise. So your job as the primary care provider is to get either a pelvic ultrasound or an endometrial biopsy or both. And if there's any pathology there, that you refer to a gynecologist to have that dealt with. Most of the time, postmenopausal bleeding is not in a volume that causes problems for the patient. It's not usually associated with pain, but there are times, such as with polyps, that it can cause large amounts of bleeding, and in that case, the patient may need to have some sort of procedure or other treatment, but most of the time, it's just a matter of ruling out cancer. Osteoporosis is one of those things that we talk about in a couple of places, but it does pop up a little bit here in women's health. It's very common, mostly in women over the age of 50. Across the lifespan, about 1/3 of women will have this. Our treatments are going to be weight-bearing and resistance exercise primarily, and then we can add in pharmacologic medications. Premenopausal women can get osteoporosis, but there's no standard definition for how to diagnose it. Usually it's considered whenever the Z-score is less than 2.0 on a DEXA scan. And then when we treat women who are premenopausal, we treat by treating the underlying cause. In postmenopausal women, there are a lot of options. If it's been a while since you've studied pharmacology, I suggest that you read through the notes here and make sure that you understand the prescribing characteristics for bisphosphonates, especially estrogens, and then you may want to look at the SERMs as well. They have some characteristics which you should know before you take your APEA test and which you'll be expected to know on your board exams. Okay, so urinary incontinence is the last big section that we go through because it comes up in the women's health section frequently. Urinary incontinence is basically defined as any time there's an involuntary loss of urine from the bladder. It's so frequent that most women would consider it normal, but it is not normal. Different studies estimate different amounts, but between 5 and 69% of women will have urinary incontinence. About a quarter of older adults and almost half of institutionalized adults have this as well. So your normal bladder will store urine and expel it when necessary. You need a proper function of the detrusor muscle to contract and the urethral sphincter, which maintain closure pressure under the control of the nervous system. The bladder has 3 different types of innervation from the nervous system: parasympathetic, sympathetic, and somatic. When the bladder is storing, the urethral closure pressure is higher than the abdominal pressure. In normal voiding, that urethral pressure will fall and the bladder pressure will rise, and that allows the detrusor sphincter to open. There can be transient or persistent urinary incontinence. We do worry a little bit about some red flags associated with incontinence, and those include hematuria, chronic UTI, or dysuria with leukocytosis. A bladder diary can be incredibly helpful in helping to sort out what type of incontinence the patient has. You also want to make sure that you are evaluating your patient for medication and alcohol use, because some medications and alcohol can increase the risk of incontinence. You want to make sure that when you do your assessment, you're looking at other medical conditions, functional and cognitive abilities, which might allow for incontinence to occur. You can take a voiding history that gives you some more information about the patient's normal daily habits and the characteristics of their incontinence. And then when you're doing your physical exam, you really want to focus on the abdominal, the pelvic, the skin, and the neurologic exam. The skin exam is really focused actually on the GU system to see about current estrogen sensitivity. Okay, so testing for different types of incontinence will include a urinalysis, electrolytes. You can do a test called a post-void residual, which looks at how much urine is left in the bladder after voiding. There are some other testing that can be done, including ultrasounds, urodynamic cystometrogram, and urodynamic testing. So really quick, different types of incontinence. Stress incontinence is when there is leakage of urine due to exertion. So the pressure in the abdominal cavity raises to the point that it overcomes the pressure that's holding the urinary sphincter closed. Women who have had children, have chronic constipation, or are obese are the most likely to have this issue. Kegels, biofeedback, weight loss, medication changes, and surgery can all help with this. Intravaginal estrogen can help, and then our primary medication is going to be the alpha-adrenergic agent. Urge incontinence is when the patient gets a strong desire to void and then cannot delay doing so, and so then they get a quick leakage of urine. This is usually or often part of overactive bladder syndrome. This one is treated more with behavioral techniques, so managing fluid intake, scheduling your voiding so that the bladder doesn't get too full. And then there are some medications that can be used, such as anticholinergics and antimuscarinics. However, we want to be careful with these because they have a high risk of adverse effects. They basically prevent the bladder from contracting. Botulinum toxin or Botox injections can also be helpful for urge incontinence. Overflow incontinence is when there are teeny tiny amounts of urine that leak out in a continuous or frequent fashion because the bladder is overdistended and the patient can no longer feel when they have to pee. This might be due to lack of tone in the detrusor muscle, outlet obstruction, diabetes, or use of medications. The patient should be taught to toilet in a scheduled fashion. Crude's maneuver can be helpful, and this is when you push down on the symphysis pubis while you're urinating, and it helps to make sure that the bladder empties. Alpha blockers can also be used. It's important to be aware of the risk factors for each of these different types of incontinence as well. I really quickly want to talk about functional incontinence. So a patient who is bedbound or has delirium, a fecal impaction, cannot get to the bathroom quickly, is on certain medications, may have incontinence only because they basically the need to urinate is outpacing their functional capacity. So if you can improve their functional capacity and manage underlying conditions, you can help with incontinence in this population. So you can see here this picture is of a person who is strung up in multiple areas of traction. Clearly they are going to be functionally incontinent because there's no way that they're going to get up and take themselves to the bathroom. Last time we're going to talk about is reflex incontinence, and this is basically when there's neurologic damage or a neurologic anomaly that prevents the bladder from storing emptying urine or both. So the patient will present with urgency, urge incontinence, frequency. They won't be able to empty their bladder all the way. They might have UTIs and they may lose their bladder contents. Treatment again is treating underlying conditions, and then these patients may need long-term alternatives. So for example, if they have MS, this is not going to get better, and those patients may benefit from a suprapubic catheter. Lastly, I want to talk about overactive bladder because it combines some of the elements of multiple issues here. Patients may be incontinent or they may not, but they have a sensation that they have to go often, they have to go right away, and they often get up at night. And this is because the bladder is contracting, that detrusor muscle is contracting on its own. These causes are multifactorial, but the most important thing about overactive bladder is that you need to make sure that you're not misdiagnosing this as just incontinence, because the treatment will be a little bit different. We treat this with antimuscarinic agents to prevent that involuntary contraction. So that sums up our quick overview of pathology of the GU system. I hope this has been helpful to you. If you have any questions, please remember to write them down or post them on the 24-hour office hours discussion board, and we will see you in class. Thank you.